Good afternoon, and I'll start with just introductions. And thank you, Dr. Meeks, for agreeing to come and present. This presentation is actually in coordination with Oregon Health Science University. I worked with Dr. Meeks in California, and then he moved on to my alma mater, Oregon Health Science University. His journey began in his completing his geriatric fellowship. And then as he moved throughout his career, his interest and dedication to addiction psychiatry is sort of well known in everywhere that he's worked. He works with residents and fellows, high reviews, and his patient care is exceptional. So I think the combination of the two bring his expertise to UNM, and I really appreciate it. Thank you very much.
Thank you for that kind introduction and for the invitation to present. So I will be talking about substance use and substance use disorders among older adults. And I'll just start by saying, what is an older adult? I think most people generally think 65 and older. And I would say, having done a geriatric psychiatry fellowship at a research-heavy institution at UC San Diego, in times of desperate recruitment for studies, sometimes that would slide down to 50, even 45, when there weren't enough participants. And having just crossed over the threshold of 50 myself, as Costco just reminded me with a text saying, pneumonia can be deadly for older adults. Get your pneumococcal vaccine today. I was greeted with that one morning recently. I'll personally choose to define it as 5 years older than my current age, but we'll get started, and it will flux a little bit back and forth in these studies, but generally I'm going to be referring to 65 and older.
Dr. Meeks, I think your mute audio is muted.
That's interesting. Okay, sorry about that. Okay. And let me go back a slide too. I have no financial conflicts of interest to disclose, and I'll not be discussing any off-label medications or treatments. But you didn't hear anything I said about this, but learning objectives include discussing the epidemiology of substance use disorders among older adults, discussing the unique aspects of screening and diagnosis related to substance use in older adults, what is known, what is not known about treatment of substance use among older adults. And I'll just jump to the chase. There's a lot more that is not known. And we'll describe some interactions between substances and age-related physiology and disease. So starting with epidemiology, as I'm sure people are generally aware, where the baby boomer generation has started entering that older age bracket. Around 2011 is when the first baby boomers started turning 65. The oldest boomers are 79 currently. And there is a drop-off in historical substance use after this age. There is really a cohort effect. This was the generation that really brought a lot of societal change in the 60s and 70s that included more liberal attitudes towards drug use in particular. And if lifetime illicit, quote unquote illicit, not wild about that term, but it's generally used a lot. So lifetime illicit substance use among boomers is 47% versus 19% in the prior generation. And perhaps we might also see more persons in older age groups with substance use disorders. Maybe there's a better chance of survivorship with better access to treatment and better medical advances to help people survive and live despite their substance use disorders. So overall themes, the data is not exactly what I would call conclusive or authoritative on the epidemiology of older adults, but we do have a pretty consistent survey that I'll go through some changes that are pretty interesting recently. If you're looking at studies that rely on medical charting retrospectively, there's always the possibility that ageism and provider assumptions can underestimate diagnoses. I'll talk about that a little bit. But it is notable also that substance use treatment admissions among older adults has doubled in the past 20 years. And although alcohol remains the number one diagnosis of substance use disorders among older adults, the ratio of other substances, i.e. drugs, to alcohol is increasing. Risk factors for substance use disorders among older adults, some of them are shared with adults in general, being male, being divorced, widowed or single, white, Black, ethnicity, Native American actually as well. But the ones I have underlined kind of have an intersectionality with aging, in that these things become more prevalent with aging and may be especially pertinent to risk for substance use and substance use disorders in aging, including loss, grief, bereavement, increasing levels of pain and disability, loneliness and isolation. And I'll just briefly give a mention to the Surgeon General's statement on the epidemic of isolation and loneliness and the profound health effects that has and how that really impacts our older adults in particular. Being a caregiver, when people try to do research on stress in the body, being a caregiver is often a model where they use caregivers of persons with dementia or chronic medical illness as a model of what stress is like. So, and that certainly increases as people get older, being in that role. Also, people are more often dealing with having to move out of their homes because of safety reasons that they just can't sustain their independence. And although most of us probably think of it as a positive thing, changes in career, including retirement, can sometimes be a trigger for people in terms of their identity having been tied up in their job or just having a lot of extra time on their hands that they did not have previously. Most substance use disorders start before the age of 30. A few start in middle age, and it's not unheard of, but it's pretty rare that they actually start after the age of 65. In looking at alcohol use epidemiology, this is the National Survey of Drug Use and Health, which is conducted annually. It is among persons 12 years and older, and it's has robust data that is available to the public, done by SAMHSA. And among older adults, alcohol use patterns haven't really changed that much. There is a 30-day use around a little over 40%, past year use 50 to 60%, binge drinking hovering around 10 to 12%, and past year alcohol use disorder around 4 to 5%. Tobacco use in older adults has followed an overall pattern in terms of cigarette smoking that has been declining for the past couple of decades in adults in general, and that's been true in older adults as well. Notably, although it was really talked about in teenagers, young adults, vaping also, although 1.5% is not a high number, it is double in just a couple of years among older adults who are now vaping nicotine. And the rate of nicotine use disorder does drop in older age. Some of that may be a survivor effect, having early mortality from the tobacco itself. And also, the consequences of smoking may start to catch up with people, and they start to have real tangible motivations for wanting to stop. When we look at drug use, some notable things I'll point out here. Cannabis, the attitudes really are different among baby boomers and prior generations. And the general societal normalization, deregulation, decriminalization also changes attitudes towards cannabis among older adults. And you can see almost a doubling in 4 years of the rate of past year cannabis use. This is just use, past year use, not use disorder. Among our prescription opioids, this is use in general, which would include legitimate prescription use. There has been a steady decline since about the mid-2010s, reflecting more conservative prescribing patterns due to the opioid epidemic. That's also been true in benzodiazepines in older adults, with increased recognition and kind of campaigns about the potential risk associated with benzodiazepines among older adults in particular. And there's just almost not even enough data to give good estimates for most of the other types of drugs like heroin, methamphetamine, cocaine, fentanyl. But looking at use disorder from 2019 to 2023, so over 4 years, that's a dramatic change in cannabis use disorder from 0.1 to 1.3%. Still, absolute value is not large, but the relative increase is pretty astounding. Same for prescription opioid use disorder. So even though there's fewer prescriptions going out to older adults with prescription opioids, the use disorder has actually increased. The same is true of sedative, and which is mostly benzodiazepines, but it includes some other, narcotic or controlled medication sedatives, and that also has increased despite decreased prescribing patterns. And the rate of any drug use disorder, driven mostly by cannabis and prescription opioids, increased to 3.9%, a really almost 10 times relative increase in just 4 years. So this was a study examining, and here the definition went down to 55, adults entering publicly funded substance use treatment programs who report to this central repository of data. And the graph on the left is the percent of first-time admissions that were older adults. And you can see that's steadily been increasing over that 10-year stretch. And then looking at the reason for admission being drugs only, alcohol and drugs both, or alcohol only, this reflects that shift I was mentioning with baby boomers, where the ratio of drug to alcohol is increasing because drug normalization was part of that generation, and they're bringing their drug use with them into their older age. So we'll switch gears here and talk a little bit about screening and diagnosis. So it's believed there's probably a tendency in the community amongst providers to underdiagnose substance use disorders in older adults. And there are some reasons we'll discuss that can happen. So it's easy for family, patient, provider to sort of assume that various, if you will, geriatric kind of syndromes might be explained by a lot of other variables, because often it is multifactorial. Why people are falling, are having gait impairment, why they're losing weight, why they're generally becoming more frail or having cognitive decline or having notable insomnia. Lots of things with aging and lots of other medical comorbidities could explain these things. And so you have to really, as a provider, have an awareness of the potential for substance use disorders to be involved here, to catch that. There's also other factors that contribute to the underdiagnosis. So in providers and healthcare systems, it's easy to make assumptions like that older adults don't use drugs or don't have sex or certainly don't inject drugs. So those kind of things, people tend to easily make assumptions about older adults. And there's also, even if you're not assuming that they don't do it, it feels like maybe it would be disrespectful or just uncomfortable for you to bring that up with an older adult. Some people can have ageist attitudes, sort of like, well, if the person's been using or drinking all their lives, they're 73, well, they're not going to change now. And people do change in their older age, of course. And I just put that little plug for implicit.harvard.edu. People may be very aware of that, but one of the tests you can do for yourself is an implicit bias test related to ageism. And just in terms of the system, time constraints, for primary care and trying to identify this, older adults often are bringing multiple comorbid conditions. There's only a certain amount of time. It's hard to screen and bring in everything in that limited time period. So among patients, they may be fearing stigma. I think that's decreasing as amongst the current cohort of older adults. People may be demoralized, if they have been battling substance use for decades and they have had multiple trials at stopping, then it is easy to get demoralized after that long. Or they may have internalized ageist attitudes, like that the one that I just mentioned that providers can have, where what's the point? I can't change at this age. And then family may be embarrassed to bring it up, or a lot of times there's really entrenched family dynamics that have been going on for a long time, and to try to bring about change in the person with substance use will have a lot of ripple effects that aren't always comfortable for other family members. So it's important to screen and be systematic, because we can have all those tendencies to potentially miss substance use in older adults. These are U.S. Preventive Services Task Force recommendations for screening for alcohol and drugs. This is not specific to older adults. There are no older adult specific recommendations here, but it is recommended to screen both for drug use and for alcohol use, and tobacco use for that matter. I think most primary care or mental health care settings probably have annual reminders built in for alcohol and tobacco, less often for drug use. But if you're in a clinical setting where that's a higher risk for your population, annual wouldn't be a bad thing. And in terms of what screens to use, the Audit C is probably the most popular one used. It wasn't really developed with older adults in mind, but and doesn't have a ton of data with older adults specifically, but it's probably performs okay in general. It is designed to be better than, say, the cage in detecting hazardous use, because it's really just focusing on amount and frequency, not consequences of use. And it is notable that they do adjust the question 3, which is, how often have you had X number of drinks in one setting or one occurrence, which is adjusted down to 3 or more for all older adults. It was, 4 or more, 4 or more than 3 for older adults, which is the limit for women across their age, across all ages. For men who are younger than 65, it's a higher limit. Those are limits that are up for debate, I think, whether that's actually too high in terms of potential hazards that can happen at lower rates. But currently, that's the defined healthy limits, and that's if you don't have a considerable contraindication for drinking alcohol, where abstinence is the recommendation. The cage there's one study that found it reasonably sensitive and specific in older adults, but that was for alcohol use disorder. It is really asking more for specific consequences, and so it's catching more severe use in general. It's not as effective at catching hazardous use where you could perhaps intervene. And technically, the cage asks about lifetime. Like, have you ever, whereas Audit C is in the past 12 months. The first screen that was really developed for alcohol use for older adults was the GMAST. There's a long version with 24 questions, but there is an alternative short version that's 10 items. I'll show you that quickly. It does have yes/no questions as opposed to a range of questions, which can be helpful for older adults, especially if there's a little bit of cognitive impairment. This is the short version of the SMAST geriatric. And I just underlined some things to highlight how they tailored it a little bit toward older adults, asking about have they not eaten or skipped a meal because weight loss, and it can be a presentation of alcohol use in older adults, harder for you to remember something, the cognitive impairments, using after experiencing a loss in your life, again, getting to the increased rates of loss and grief and bereavement, or using when you feel lonely, again, getting back to that risk factor of social isolation. There's another tool that's really not used that often, but just bring it up here for if like in a geriatrician setting, or maybe even a primary care is probably not going to have time to do this across the board, but this is a screen that really is even more sensitive than CAGE or Audit or the SMAS, because it also looks for conditions or medications that are a contraindication for drinking, even if the person is drinking in healthy limits. So things like hypertension or pancreatitis or cognitive impairment, liver disease, where drinking at all could be considered hazardous. There's not really any data for older adults specifically for drug use screening. These are some possibilities. The NIDA quick screen is probably the best, just in terms of if you were going to try to incorporate something routine, because it's only 4 questions. And there's a link there to various screens that could be used. Just put this here more as a reminder. We're not going to discuss all of these measures, but there are, if someone's thinking of starting someone on chronic opioid therapy, or if you're treating someone who is already on opioid therapy, there are tools for both of those scenarios to sort of screen for risk or actual ongoing misuse. Then once you do the screening, in primary care, screening, brief intervention, and referral to treatment, or SBIRT, is recommended by the U.S. Preventive Task Force. It's pretty strong evidence base, and it is tested best in primary care. Also, some data for emergency rooms. You would it's probably applicable to older adults. There just aren't a lot of studies specifically among them. Those that were done aren't that well. They're not of that high a quality, but it's still worth doing. And we won't get into the specifics of what SBIRT is, but it's motivational interviewing, informed, pretty brief interventions, and just being able to connect people to treatment when they screen positive. Talk a little bit about how the DSM criteria for substance use disorders may not fit older adults always. So a couple of things to keep in mind: if someone has cognitive deficits, taking accurate use history can be, or accurate history in general can be complicated. Collateral history may be important. People may not realize that drinking at a reduced level as you age may be the equivalent of drinking at a higher level when you were young because of physiological changes. So it's easy to rationalize that they've cut back when really they may be drinking at getting the same blood level as they did when they were younger. These days, one of the criteria is a lot of time to obtain, use, or recover. Recovery from effects may be particularly a lot prolonged in older adults because they don't have the physical and neurological reserve to bounce back. The obtaining part can be pretty easy with delivery services, the internet, and often you'll see family members or neighbors actually getting the alcohol in particular for the person. Failure to fulfill role obligations. Well, a lot of times people aren't working. They may not have that robust of a social network. So you have to try to look for what their role obligations are, but sometimes they can be pretty sparse if the person's isolated and not working. Continued use despite interpersonal problems. Again, getting back to, if you're not interacting with people a lot, you won't have interpersonal problems, even if you have problematic use. Same issue with giving up recreational activities, occupational activities. Recurrent use in hazardous situations. Driving is a very common one in younger adults, that older adults may not be driving anymore. So you may have to be creative in looking for situations around the home where it may be hazardous to drink, like using with sedating medications or using despite needing an ambulatory assist device. We'll talk a little bit more about withdrawal here in just a sec. I mentioned before about tolerance, how the person can be drinking essentially and getting the same effects from less alcohol because of physiological changes. So some of those physiological changes, there's more fat versus lean body mass as people age. There's less alcohol gets distributed into the lean body component of the body. So there's less place for the alcohol to go, so it increases the concentration. The liver isn't quite as effective. The blood-brain barrier is more permeable. Things get into the brain more easily. and the brain becomes more sensitive to a lot of these substances. Okay, lots of health effects, obviously, that intersect with diseases that are age-related. Atrial fibrillation, holiday heart, as it was commonly called back in the day, where binge drinking would often present with atrial fibrillation. It's a risk factor for hemorrhagic stroke and hypertension, many types of cancers in the gastrointestinal tract, liver, and breast, peripheral neuropathy, and we'll talk a little bit more about alcohol and cognitive impairment. We mentioned falls as something that can be pretty complex in terms of the cause, but alcohol certainly can cause it by a variety of ways. It causes ataxia from impairing the cerebellum. The peripheral neuropathy causes people to not be able to feel where they are in the world, and so that causes imbalance. People have osteoporosis, which can make them more susceptible to fractures, and also as people age, and also related to alcohol-related brain atrophy, there is more of a space between the brain and the skull, which makes older adults, especially those drinking, susceptible to brain bleeds, subdural hematomas. Suicide is, of course, a risk that increases, especially among older white men, and alcohol is often a factor in that. Looking at pharmacotherapies, there's really very scant data specifically among older adults, so I'll just broad stroke it. We don't use disulfiram as much because those really unpleasant reactions can actually sometimes be dangerous in with certain medical conditions that become common in older adults. So the dizziness, the hypotension, the tachycardia, nausea, vomiting, sometimes those are not just uncomfortable, but problematic for older adults. There's no real data for our acamprosate, but it is renally dosed, so we do lose kidney function with aging, and older adults are more likely to have kidney disease. So just need to keep that in mind when dosing it. Naltrexone had, a small positive study. It's still probably most people's first line. It's once a day, and probably has the most robust evidence in terms of adults in general. Older adults may encounter situations more often where they have acute pain or need surgeries, so you just have to keep that in mind. Naltrexone will block the effects of opioids used for those situations, so it does require some planning and maybe even a medical alert bracelet for emergencies. And I do like general pharmacology for all of geriatrics is start low, go slow, but go. In terms of alcohol withdrawal, there's more likely to be complicated alcohol withdrawal with increased age, meaning seizures or delirium tremens. With increasing age, there's more prior episodes of withdrawal, and that causes a kindling effect where each episode of withdrawal primes the brain to have more severe withdrawal subsequently. And there's also less CNS reserve, so it's more, people become delirious more easily with age. And also because a lot of comorbid medical conditions can destabilize even with mild to moderate alcohol withdrawal. More often, we will use a higher level of care for older adults when we're doing withdrawal management than we might for the same level of withdrawal symptoms for younger adults. Also, benzodiazepines become more potentially toxic with older adults. There was a study that confirmed, like it is true among adults in general, that if you use a symptom trigger protocol in the hospital in particular, not using a fixed taper, that does reduce benzodiazepine use, which is important in producing falls and delirium, part of the delirium that can develop during withdrawal management can be benzo-induced itself. We use the shorter acting benzos like lorazepam or oxazepam that don't depend as much on liver capacity to avoid toxicity. And of course, don't forget thiamine. In terms of alcohol and dementia, there is some suggestion alcohol may be a little protective of dementia, but not to the degree I would ever say recommend alcohol to prevent dementia. Alcohol use disorder itself definitely is a risk factor for dementia in general. There's some degree of cognitive impairment in 50 to 70% of people with alcohol use disorder who are tested. Not dementia, but some cognitive impairment. The DSM criteria for alcohol-induced or alcohol-related dementia are very vague. The best criteria that I've ever run across are extremely old and not all that well tested. I won't go into them in detail here, but suffice it to say, it's quite subjective to try to diagnose this, but I will leave these criteria for your review if you're interested in digging into that at some point. If you're trying a differential diagnosis for a patient, trying to determine if it's alcohol related or not. One important point I will say about that is, in general, if the person stops drinking, if it's truly alcohol induced dementia, the cognitive decline should stabilize, often even improve a little bit. Now moving on to tobacco and nicotine. I won't belabor all of the negative physical effects of nicotine and tobacco. I'm sure most people are well aware, but obviously cardiovascular morbidity. The vast majority of abdominal aortic aneurysms and peripheral vascular disease are attributable to smoking. 30% of all cancer deaths are from smoking. Overwhelmingly COPD and lung cancer. Smoking does contribute to osteoporosis, cataracts, and dementia. And people should not be demoralized or give up, because even when you're older, if your life expectancy is even just 5 years, there's substantial benefit that you can reap by stopping. Again, not many studies with tobacco pharmacotherapy in older adults. Nicotine replacement is usually just dosed the same way based on the person's use history. Bupropion, same general principles with older adults, start lower, but often have to go to similar, if not the same, dose ranges. Varenicline does require renal dosing, so you just do have to pay attention if there's renal impairment. And I will just summarize these studies to say in general, I would go with what the general adult data suggests, that the best data are for varenicline or combination nicotine replacement therapy, which means a patch plus a short-acting type of nicotine replacement. Now, prescription medications, primarily opioids and benzos. So opioids were the primary substance in 20% of SUD admissions among older adults 55 plus in one study. And most of the drug-related deaths in older adults involve opioids. And these are drug overdose deaths of all kind across this time period through 2019. You can see 65 and over or smaller, but I'll show you some data that I extrapolated to 2022 and 2023. These kind of middle adult years, there was, during the pandemic, a huge spike in overdose deaths. As I'm sure most people are aware. There has been a little trend to decrease, though, in the last year or two. However, if we're looking at 55 to 64 or 65 and older, that trend did not hold true. There was a spike, but there was actually an increase, a continued increase, not the slope slowed down, but still a continued increase in overdose deaths in those populations. Pain and insomnia are common in older adults, and so that is why they generally get prescribed a lot of sedative hypnotics and opioids. Most of them are coming from a legitimate prescription, but the main concerns are falls and cognitive declines. And similar to other substances, the aging body doesn't metabolize and eliminate these substances as effectively in general. And so even staying on the same dose over many years, your blood level can start to creep up, the toxicity can start to creep up, and your brain reserve can be more susceptible to the side effects. There's very limited information. I sound like a broken record, but this is just generally the truth. There's limited information on medications for opioid use disorder. Generally, when there have been studies, it looked like older age was predictive of better outcomes. Buprenorphine, as in most adults, is generally the first line just for ease of use and efficacy, as opposed to methadone or naltrexone. And it's important to note the Support Act in 2020 expanded Medicare Part B coverage for opioid treatment programs. So we cover the methadone and the bundled services that go with attending an opioid treatment program. There was some suggestion that, there could be lots of factors, but that over that time period, that could have contributed to more fills of medications for opioid use disorder, including more of methadone and buprenorphine, and buprenorphine remains the most commonly used form of MOUD for older adults. There can be challenges, in particular with methadone for older adults. It is not eliminated as effectively. If you're doing an induction, starting it, older adults are more susceptible to an accidental overdose, so you have to be careful. Things that become more common in older age, you have to take into consideration: sleep apnea, COPD, constipation, QTC prolongation. And we often encounter in our OTP with older adults lots of just systematic issues. They may start to have cognitive decline. If they don't have support at home, are they safe taking home medications? But if they don't have cognitive decline and we require them to come to the clinic more often, are they then driving with cognitive impairment? So we get into catch-22s, and getting someone into assisted living or skilled nursing facility, especially with methadone, but even with buprenorphine, can be challenging. SNF pharmacies cannot dispense methadone for OUD. It still has to come from an OTP, which introduces an extra wrinkle for them. There's already stigma associated with these medications, and so there is just overt discrimination in accepting these patients into SNFs. Briefly to cannabis, this just graphically displays that increased use that I showed at the beginning. So among older adults, older adults are more likely to use oral versus smoking, but I think that's going to change over time with baby boomers. That'll probably not be true, I would guess, within 10 years or so. They are more likely to endorse using medical cannabis as opposed to obtained without a prescription. Again, I think that's probably likely to change over time. The only things medically that have really any solid data for medical cannabis are chronic pain, chemotherapy-associated nausea, vomiting, possibly spasticity and multiple sclerosis, and certainly not applicable to this talk, a very specific pediatric seizure syndrome. And the will possibly, or the age-related conditions that have been looked at most for medical cannabis or cannabis in general are Alzheimer's, Parkinson's, and cancer. There is data is all over the place. Suffice it to say, it's kind of a wash. There really is no strong data. It might be a tiny direction favoring cannabis for sleep and Alzheimer's and for agitation and Alzheimer's, but it's nowhere near like FDA approval level data. And really the data was way more robust, as you might guess, if it was not a randomized study. The randomized studies that were positive used very controlled amounts of these pharmaceutical versions of THC or THC CBD combinations, not just however much marijuana you decide to smoke on your own. And there are medical issues that come up for older adults with cannabis. It causes rapid heart rate, possibly myocardial infarction and arrhythmias, not emphysema or cancer, but it can cause some respiratory issues. Certainly, we know psychosis and can be an aspect of cannabis use. Both THC and CBD have various data to show they do inhibit cytochrome P450 enzymes that we're not sure what the clinical significance is, but just to be aware that could possibly affect increased blood levels of certain medications. And there does seem to be, most of the data on cognitive impairment is really on acute intoxication effects, where clearly attention, working memory, executive function, and driving abilities are impaired. People will tell you their attention and memory is better, but that's because they're having an altered sense of reality in that moment. When you look objectively, these things are worse. In terms of chronically, we could speculate, but there isn't hard data. Sometimes it's hard to know what to communicate to patients about cannabis and medical cannabis. So I put this resource here. It is a sort of an OHSU plug. It is a website that does iterative updates on evidence-based reviews of different indications for cannabis. And it also just has some basic educational things that that providers may not know, but that things that patients know that we don't know. And I will wrap up here talking about psychosocial treatments. So this is really the mainstay. We do use medications. They are underutilized in older adults with substance use disorders, but probably what most people are going to access as older adults for substance use are psychosocial treatments. A lot of people who have just harmful or hazardous use that are identified like in primary care don't necessarily need SUD specialty care. However, there is a dearth of older adult tailored substance use specialty care. Less than a quarter of programs have services really tailored to that. When they surveys SUD specific treatment programs. And I think not only are baby boomers bringing more drug use, they're also more likely to seek, they're more treatment seeking. So that combination is going to bring a lot more need for treatment, and we do not have the infrastructure for that. And programs are generally a lot of times not designed to deal with some of the unique cognitive and medical issues of older adults. So some general things that may need to be adapted include attention to sensory impairment, the pace of materials, consider use of telehealth technologies if transportation barriers are there for older adults, age-specific group programming. I'll mention that in the next slide. Don't assume that all older adults want that, but we have programming here at in our clinic, and it's very popular with our older adults. And if someone has, mild to moderate cognitive impairment, you can still do things like behavioral therapy or therapy with a family member present, basic problem-solving therapy, things that don't require as much of a cognitive load. And so the themes that come up often in these age-specific groups are grief, loss, coping with functional independence loss, medical issues, loneliness, role transitions. So it can be very helpful to have an age-matched peer group for that. We're getting to the end of time. I do want to leave time for questions. I will say that that's a resource for family members there from Hazel and Betty Ford. If they want to try to address substance use with a family member, an older adult family member. We need more residential and inpatient programs that can accommodate the needs of older adults, not just outpatient programs, but residential programs as well. There's a dearth of trials. In general, older adults, though, when they are looked at, have just as good outcomes, and the psychosocial treatment should be offered to them. So I'll wrap up there to leave a little time for questions.
Thank you, Dr. Meeks. Do we have any questions? Well, I guess not. Is there somebody in the chat? Well, I've been seeing a lot more phenobarbital used for alcohol withdrawal. Do you have any thoughts on this?
Yes, I do think in general it's a good treatment, often used in the emergency room or ICUs, not really outpatient settings. There is more potential for cognitive impairment and respiratory suppression in older adults. So I personally haven't seen it used that much in older adults. I tend to have seen it used in a younger adult population. The one potential benefit that could have is that this is, again, not a study conducted in older adults, but in the studies that used phenobarbital-driven protocols, some studies showed that they needed overall less medication and actually had shorter length of stay and less delirium and less falls. So, it just really would need to be studied to have a strong conclusion, but caution for dose-related side effects is definitely there, and not in an outpatient setting at all.
Okay, and the second part of Dr. Wiley's question is, a Geri Psych colleague was recently telling me about respiratory depression in opiate-naive adults started on low-dose buprenorphine. Is that typical?
In opioid-naive adults started on low-dose buprenorphine. It's not typical, but it can happen. It's not that buprenorphine causes no respiratory suppression. It is a partial agonist for about 40% intrinsic activity. So if you have no opioid activity going on, you're opioid naive. If you're susceptible because of decreased respiratory reserve, decreased respiratory drive, any kind of respiratory illness, sleep apnea, and certainly it could do that. There are studies where it compared respiratory suppression with morphine. In a couple of those studies, it was equivalent to morphine in opioid naive patients. Most of the time, that has not been the case when compared to full agonists. But for instance, children absolutely can die from a buprenorphine overdose in particular. They're certainly susceptible. And so a lot of things that are true sort of in younger age groups start to become true a bit too as we age in terms of physiological susceptibility.
Okay, thank you very much for Dr. Meeks. I really appreciate your time. It's nice seeing you too.
Yes, likewise. And thanks for the opportunity to present.
Okay, thank you. Talk to you later.
All right, bye-bye.
Bye-bye.